Welcome to the Deep Dive. This is the show where we unpack complex topics, sift through the latest research, and really try to deliver the most important insights directly to you. We know your time's valuable, and our mission is always to cut through the noise, leaving you well-informed and hopefully ready for those aha moments. Today, we're unraveling a story that's been quietly evolving in the world of prenatal care. It's the story of a silent virus, a decades-long debate, and a recent, pretty groundbreaking shift in national policy. We're talking about cytomegalovirus, or CMV, and how France is now stepping onto a new path, a path that could profoundly impact future generations.
That's absolutely right. Our focus today is specifically on the Hauteuil de Santé, the HAS opinion that came out on June 5, 2025. This document, it really is a pivotal moment. It now advocates for systematic CMV screening during pregnancy. That's a major departure from previous stances in France. So our goal today is to really dissect the compelling arguments that led to this decision and show why it's seen as such a significant advancement in the fight against CMV-related complications.
Okay, so let's set the stage a bit. For many of you already deeply invested in pregnancy follow-up, CMV, well, it's a familiar challenge. This virus is incredibly widespread, often asymptomatic in healthy people, yet it can lead to severe disease, especially in those with compromised immune systems. And when someone has a primary infection or maybe a reactivation, the virus shows up in various body fluids, urine, saliva, vaginal secretions, semen, breast milk. It makes infected individuals ongoing viral reservoirs. What's particularly intriguing, I think, is that due to viral variability and, well, incomplete immunity, reinfections with different strains are actually possible. It adds another layer of complexity, doesn't it?
Absolutely, it really does. And congenital CMV, or CCMV, it remains the most common congenital infection globally. We're talking anywhere from 0.5% to maybe 2% of all live births. It is, unequivocally, the leading non-genetic cause of congenital sensorineural hearing loss and also significant neurological damage. The most severe sensory-neurological effects. They're predominantly linked to primary infections happening during the first trimester. In those cases, up to 40%, maybe even 58% of infected newborns develop serious long-term sequelae. That's a huge number. Overall, roughly 17% to 19% of the total CMV-infected neonatal population can experience long-term issues, including, sadly, death in about 3% to 4% of cases. So serological testing done before 14 weeks of gestation is crucial. It helps identify primary infection that happened within 3 months around conception. But it's important to note it's not particularly informative for women who were already immune before pregnancy. Historically, without systematic screening, fetal infections were largely picked up because of ultrasound abnormalities. But we know the sensitivity of routine ultrasound in predicting neonatal symptoms is actually quite low, only around 25%.
Right. And if we connect this to the broader context, for a very long time, France, specifically through the Haut Conseil de la Santé Publique, the HCSP, held a pretty firm position against systematic CMV screening in pregnant women. This wasn't just a casual stance, was it? It was a carefully considered policy.
Precisely, yeah. The HCSP's 2023 opinion, which updated its 2018 recommendations, explicitly maintained this position. And their reasoning was, well, it was multifaceted. It reflected the scientific understanding and the data that was available at the time. So while individual cases of CCMV could be devastatingly severe, the public health impact at a population level, it was considered relatively modest. Serious sequelae were estimated to affect only about 1 to 6 per 100,000 newborns. Other key concerns included questions about the overall reliability of the available serological tests back then. Also, the incredibly short window of opportunity for any effective intervention. There were uncertainties surrounding the efficacy and the safety of prolonged high-dose Vlasicolovir treatment, and importantly, issues regarding patient acceptability. There was a real fear of causing undue anxiety among expectant mothers. And back then, the cost-benefit balance, well, it just didn't seem to favor generalized screening.
That's the backdrop. Okay, now let's fast forward to this HAS opinion of June 5, 2025. This is where it really gets fascinating. The HAS has now reversed that long-standing position. They're officially recommending systematic CMV screening of pregnancy across France. That's a monumental shift in national policy. What specifically led the HAS to make such a profound change? I mean, what was the tipping point?
That's the core question, isn't it? And it really boils down to several compelling arguments, all backed by updated scientific evidence that, well, truly shifted the needle. The first, and you could argue the most crucial argument for this reversal, lies in a rigorous reevaluation of valacyclovir's efficacy. Now, previous studies like the Shaharni-Sun 2020 randomized controlled trial had suggested some efficacy, sure, but the HCSP's earlier assessment had highlighted certain limitations in that data. However, the HAS 2025 opinion is based on a comprehensive new meta-analysis, a really robust one. This analysis integrated data from that pivotal RCT, but also combined it with 4 additional observational studies. These were from Farid Barden in 2021, Egloff and Amir both in 2023, and Zamarchi also in 2023. And this wasn't just, simply adding up the numbers. It was done using a pretty sophisticated statistical approach. It's known as Rover and Fried's normal hierarchical model.
Okay, so not just another study, but a much deeper reanalysis that kind of flipped the script on valacyclovir's role. So what did this advanced analysis reveal? What does statistically significant protective effect actually mean for, say, a busy practitioner listening to this? Are we talking a small improvement or something really transformative?
Oh, it's transformative. The findings demonstrated a statistically significant protective effect of valacyclovir on vertical CMV transmission across all the analyzed scenarios, every single one. The odds ratios, they range consistently between 0.40 and 0.49. So, for practitioners, what this means is a substantial reduction in transmission risk. We're talking essentially halving it, or maybe even more. That's when valacyclovir at that specific dose, 8 grams per day, administered until amniocentesis was used. So this treatment has now been clearly shown to reduce both mother-to-child transmission and the incidence of symptomatic congenital CMV at birth. And furthermore, there was a Vigibase analysis, which looked at pharmacovigilance reports on a very large scale. It found no significant disproportion in things like malformations, early miscarriages, fetal deaths, low birth weight, or prematurity in women treated with valacyclovir compared to those on other medications.
That's reassuring.
It is. Now, maternal side effects like nausea and headaches were reported, but let's face it, those are pretty common in early pregnancy anyway. And severe adverse events like renal insufficiency were rare. Very rare. So this new consolidated evidence on both efficacy and safety, well, that was a definitive game changer. It removed a major barrier to considering systematic screening.
Yeah, that truly changes the calculus, doesn't it? With such strong evidence for an effective intervention, how did this impact the perception of CMV as a public health problem? Did that low prevalence of severe cases still weigh as heavily?
Not in quite the same way, no. The HANAS opinion now places a much stronger emphasis on the severe individual consequences of CCMV. So while the prevalence of severe sequelae at a population level in France is still low, you mentioned around 0.06 per thousand for serious disabilities, the argument shifts. It shifts to the profound and often irreversible impact on the affected children and their families. CMV is without question the primary non-genetic cause of congenital sensorineural hearing loss. It accounts for a significant chunk, maybe 5% to 6%, of all congenital deafness cases. And it also leads to substantial neurological damage, intellectual disabilities, neurocognitive disorders. So the focus moved. It moved from the overall rarity at a population level to the critical importance of preventing such devastating outcomes at the individual level. It acknowledges the immense personal burden.
Okay, that makes sense. Let's unpack another one of those previous concerns, the reliability of the tests themselves. Were the diagnostics considered robust enough for systematic screening now? What changed there?
Right, that was a big one. The ACE-SS acknowledges the inherent complexity of CMV serology. I mean, it's not straightforward, but it confirms that diagnostic reliability is indeed sufficient for systematic screening now. Screening initially relies on serology, looking for specific IgG and IgM antibodies. Standard stuff. If those IgM antibodies are positive, then an Ig avidity test is performed. That helps differentiate between a recent primary infection, which is what we're most concerned about, and a past, less risky infection.
Okay.
And to address the nuances of interpretation, a consensus logogram has been developed. This was done by leading expert groups like the European Congenital Cytomegalovirus Initiative, ECCI, and the French National Reference Center for Herpes Viruses, the CNR herpes virus. This logogram provides a standardized interpretation algorithm that significantly enhances consistency and accuracy across different labs. Huge step forward.
Standardization is key.
Exactly. Now, while there can be a number of false positives, estimated somewhere between maybe 300 and 1,700 annually in a population of 700,000 pregnant women, laboratory performance and external quality controls is generally excellent. That indicates high precision. And for the definitive fetal diagnosis, amniocentesis with PCR detection of CMV DNA in the amniotic fluid, well, that remains the gold standard. It demonstrates nearly 100% specificity.
Right.
But it's important to remember a negative amniocentesis result before 20 weeks gestational age, or if the mother has been on valacyclovir treatment, it still carries a small residual risk of CCMV.
What about the critical timeline, that window of opportunity for intervention? Was that reassessed? Is it now seen as more feasible within routine clinical practice?
Yes, it absolutely was. That was another key piece. The period between a maternal viremia, when the virus is in the blood, and viral excretion in the amniotic fluid typically spans about 6 to 8 weeks. Now, for a valacyclovir treatment to be most effective, it should ideally be initiated within 3 to 5 weeks of the maternal infection.
Okay, quite early then.
Yes. This allows for treatment to begin before 13 weeks of gestation and continue for at least 7 weeks before the amniocentesis, which is generally performed around 17 weeks. The HHS now deems this time frame to be entirely feasible within routine clinical practice. That indicates that with early screening, intervention can occur within this critical window. That was a significant concern in previous analyses, but it's now seen as manageable.
Okay, so we have stronger evidence for treatment, a shift in focus to individual harm, more reliable testing, and a feasible timeline. With all these strong scientific and clinical arguments lining up, let's connect this to the bigger picture. How is this monumental shift being received, by patient groups and healthcare professionals on the ground? Is it acceptable from their perspective?
That's a great question. The HACE actually took a very consultative approach here. They reached out to various stakeholders. That included patient associations specialized in perinatality and CMV. 3 out of the 9 contacted associations responded, and their feedback indicated, broadly speaking, global favorability towards systematic screening.
That's positive.
It is, but they emphasize some crucial conditions. There must be clear, comprehensive, and accessible information for pregnant women. That's non-negotiable. And, equally important, robust training for healthcare professionals to manage the screening process and the subsequent counseling effectively.
Right. Information and support are key.
Absolutely. And international studies also underscore high public acceptability. There was one study, for instance, at the Minnesota Fair. It showed that a remarkable 96% of women believed screening should be offered, and 77% said they would choose prenatal screening if they were fully informed about CMV incidence and risks.
Wow, that's high acceptance.
Very high. It clearly indicates public acceptability when information is well provided. Now, concerns about maternal anxiety during the diagnostic process were noted, and that's a valid concern we absolutely must address. But the emphasis now is on mitigating this through clear early communication and strong professional support. The aim is to ensure that the benefits of early detection really outweigh any potential psychological burdens.
That makes perfect sense. It's about managing the process well. Okay, so given the potential costs of rolling out a nationwide screening program, what about the economic angle? Does this systematic approach make financial sense now, whereas maybe it didn't before?
Yes, the economics definitely played a significant role in this Hefe's opinion. Updated analyses added substantial weight to the argument for systematic screening. Recent studies, including a 2025 Canadian study by Elhachem and colleagues and a 2022 U.S. study by Fisher and colleagues, now support systematic screening as the most cost-effective strategy. Yeah, in the Canadian model, for example, systematic screening with valacyclovir was found to be the most cost-effective option in, get this, 96.36% of simulations.
Almost always the best financial option then.
Pretty much. And in the specific French context, while the strategy does generate some additional costs compared to, say, doing absolutely no screening, it is found to be more efficient than the current practice, or the previous practice, I should say. It yields a highly favorable cost-effectiveness ratio, $893 per avoided congenital infection.
So a good investment in health outcomes.
Exactly. This robust new evidence on cost-effectiveness really strengthens the case for widespread implementation. It shows it's not just clinically beneficial, but it's also fiscally responsible in the long run.
It's actually quite rare to see medical and economic arguments align so clearly like that. It must be, well, a relief for policymakers, knowing they can move forward with a strategy that's both good for patients and fiscally sound. Finally, what about the ethics? What were the ethical considerations that the HHS framework carefully weighed in making this really monumental decision?
Yeah, ethics are always central. The Hass indeed gave careful consideration to the ethical implications. They grounded their recommendation in the 4 core principles of healthcare ethics: beneficence, doing good; non-maleficence, avoiding harm; autonomy, respecting individual choice; and justice, ensuring fair access for all.
Right, the 4 pillars.
Exactly. So the core principle of beneficence strongly supports intervention to prevent severe harm, which CCMV clearly represents. Non-maleficence ensures that potential harms from the screening itself or the treatment are minimized. Autonomy is highly emphasized. There is a real commitment to providing complete and unbiased information to expectant parents. That allows them to make truly informed choices about screening and then the subsequent management options.
Informed consent is critical.
Absolutely. And finally, justice. This calls for equitable access to the screening program and the necessary follow-up care across the entire territory of France. It means actively addressing potential disparities in healthcare access. So the overall stance is that with the right information, proper support, and equitable access, systematic screening aligns very well with these core ethical values.
It's truly fascinating, isn't it, how new data can fundamentally reshape our approach to a long-standing public health challenge like this. And while many countries, you mentioned the US, UK, Canada, Belgium, have historically not recommended universal CMV screening, this new HEST stance puts France alongside countries like Italy, perhaps reflecting an evolving international perspective, really driven by the latest evidence. This deep dive really highlights the dynamic nature of medical science and the critical role of continuous reevaluation for achieving the best patient outcomes.
It really does. This deep dive into the HAS 2025 opinion, it truly underscores a significant and I think very well-reasoned shift towards systematic CMV screening in pregnancy in France. It's a decision driven by, well, several key things. That rigorous reevaluation of valacyclovir's efficacy through new meta-analyses, a renewed and crucial focus on the profound individual impact of congenital CMV, and these updated analyses on test reliability, intervention feasibility within clinical practice, patient acceptability, and that favorable cost-effectiveness ratio. The integration of all this robust new data was absolutely pivotal in moving beyond those previous uncertainties and really paving the way for this major advancement.
Indeed. And this isn't just a policy change on paper, is it? It's about providing healthcare professionals like you, our listeners, with more robust tools and a clearer pathway, a pathway to identify and potentially mitigate the severe consequences of CMV for future generations. It reinforces that dynamic nature of medical guidelines, the continuous pursuit of better patient care, always adapting to new evidence.
Absolutely. And as we move forward, this systematic approach, well, it will inevitably bring new questions, new avenues for research too, things like optimizing treatment protocols further, or the ongoing development of effective vaccines, which is the ultimate goal, perhaps. The journey to fully eradicate the burden of congenital CMV is certainly ongoing, but this represents substantial, tangible progress for patients and their families in France.
So as you integrate these evolving guidelines into your practice, perhaps consider this. How might this new emphasis on early detection and intervention fundamentally change the conversations you have with expectant parents? And what new opportunities does it create for even more collaborative and comprehensive care in the years to come? Thank you for joining us on this deep dive.